Perfetto. Ok, dovremmo esserci. Ci siamo, ok. Allora. Good morning, everyone. Welcome back to our international ground rounds. As this is the third Saturday we pass in, and with the pleasure to having Paolo Battaglia with us today. Good morning, Paulino.
Good morning to everybody. Good morning, Puya.
So, as far as we are going forward, as we announced today, Paul and I are going to talk about the amazing flap that he developed a few years ago. It was back in 2014 and 15. So today, Paolo is going to talk about that, and he's going through a step-by-step approach on how to harvest this flap, and then I will report some of our results, the preliminary one and the long-term outcomes. Because in 4 or 5 years, everything changed. We got more data, and he will start with the technical nuances, and then I will proceed with the data. So, Paulina, the torch is up to you. You can share your presentation.
Yeah, thank you very much. As usually, I want to thank Olver as a team, and particularly Dr. Giorgio Sileo, that helped me in building up this material for this presentation. And I'm honored to be to evolve this work, this idea with Dr. Puya, that was with us in Varese for a long time, and we focus on this topic mainly, and he helped us too much. And what is the idea? Usually, in order to reconstruct the skull base, the mainly used techniques were two. The first one was the multi-layer technique, and so we use the fasciolata to put intracranially, intradurally, and then the fasciolata intracranially, extradurally, and an overlay layer with mucoperiosteum or with fascia again. And the other technique was the very diffused and used Haddad flap. But the idea was, in particular, in selected cases, when the tumor was a unilateral, where there was no risk of multifocal spreading of the tumor, and when the septum was not involved in this case, the idea was to use a pedicle, flap pedicle on anterior ethmoidal arteries in the contralateral side of the lesion. And the advantage of the pedicle flap, as you all know, is to reduce the crusting instead of fasciolata, and of course a more fast healing process. And so the so-called flip flap is a flap pedicle on anterior, as you can see here, and posterior ethmoidal arteries. These arteries gives septal branches, and that goes toward the septum. So it's a very aerated flap. The blood supply is huge and is very resistant. And then I'll show you why perhaps sometimes it seems to be better than that flap. So as you can see, we use in these cases where there is a monolateral resection of the dura. Also, it can go from the frontal sinus till the sphenoidal sinus, so it can involve all the anterior skull base. As you can see, when we have such kind of defects, we use fasciolata to cover the brain and fasciolata between the dura and the bone, and then we cover with this flap as third layer. We published this, and then we will show you our results. And as usually, we start from the lab, so from dissection, and then we go towards surgery, as we did in developing this kind of flap. And as you can see, we are in the situation, in the same situation I told you before. You see, we are in the left nasal fossa, here the sphenoid, the pituitary cella, papyracea here on the left side, and septum here on the left side. We have such a kind of defect, can be more or less, but the idea is that it has to involve the anterior skull base. So you can see we put some fascia covering the brain and between the dura and the bone. And then you see we removed the mucoperiosteum of the left side. As you can see here, we are on the left side and we are removing the septum and the mucoperiosteum of the left side. This is the bony part of the septum, and we remove all till the floor of the nasal fossa. Here posteriorly, we have the sphenoid side, sinus opened. And we try to maintain, as you can see, the mucoperiosteum, mucoperichondrium of the contralateral side. So the removal of the septum continues posteriorly till the rostrum. Here you see left choana, and we remove the ostium, enlarging removing the anterior wall of the sphenoid bilaterally. So here we are removing again the last part of the mucoperiosteum of the left side, as you can see. Now we remain with the defect without the posterior third of the septum, and is preserved the mucoperiosteum of the contralateral side. Of course, if the tumor involves the septum, is too risky to try to spare the mucoperiosteum. So only in case of monolateral lesion. As you can see, you can preserve also the mucosa, the mucoperiosteum that goes towards the nasal floor. Then here, the anterior incision of the flip flap that is anterior, of course, to the posterior wall of the frontal sinus. As you can see here, posterior wall of the frontal sinus, you don't have to go down straight, but you have to come anterior and then down, because if you down, you will flip the flap, it will have to cover the anterior part of the anterior skull base. So one trick that I suggest you is to expose the posterior wall of the frontal sinus, remove the crystal, we show you in live surgery, and then not to go straight down, but to come anterior toward the anterior part of the nasal septum, anterior to the axilla of the middle turbinate. In such a way, you will flip the flap and you will cover the anterior border of the defect. Okay, so we detached anteriorly. Now it depends how you need the flap to be large. You can cut just here where the septum becomes nasal floor, or laterally, and also you can extend the flap till the inferior meatus. And then I show you how huge surface it will cover this flap. So we'll go posteriorly till the insertion of the soft palate at the level of the hard palate. Okay. Now, of course, we have to perform the posterior incision, and here is at the level where the septal branch of the sphenopalatine arteries runs here posteriorly. So inferior, we complete the inferior incision of the flap and try to turn. But if you don't cut here, you see the flap will stay attached to the basis sphenoid. And then in such a way we can turn the flap up and cover all the defect, as you know. As you can see, the flap, if you extend at the level of the nasal floor, can cover also the orbit over here. It's very frequent that a tumor it's attached and pushed at the level of the papyracia. So it's very frequent that we remove the papyracia, leaving the periorbit or removing also the periorbit. So in such a way, this flap can cover the anterior cranial base and also the medial wall, the medial part of the orbit with the fat that sometimes is exposed. As I told you before, if you extend your anterior incision superiorly and anteriorly, when you turn this flap, it can cover also this area. One mistake is to go straight and down when you make the anterior incision, so you cannot cover this area, and this is the major part of the risk, is the risky area where you can have CSF. But one thing that, in my opinion, is better than the adult flap is that in such a way you can cover without interruption the medial part of the defect. The medial part of the defect is usually where the falx, the basal parts or the falx attaches to the bone. And then you cannot insert very well the fascia. And the adad is only pushed at this level, but you know the liquor can go out. In such a way, you seal perfectly the medial part of the defect, where you have the most time the CSF after this cranial base resection. So for this reason, if I can, I prefer to use the flip flap instead of the adult flap. Now just two cases when we use it in tumors, but of course in selected cases covering the defects after in a patient with a CSF leak with a meningoencephalocele. So I will show these two different cases. So this is a case with, you see this tumor involving the ethmoid on the right side. And you see here the tumor involving the posterior ethmoid. So we start as usual to remove the tumor with a centripetal technique. So this is the medial turbinate. We make our horseshoe incision at the level of the maxillary line and on the anterior part of the septum, then down at the level of the fontanelle area. We need our landmark, so we open the maxillary sinus, and then by a periosteal dissection, we dissect the ethmoid and the upper part of the roof of ethmoid and the olfactory cleft. So we remove the ethmoid with the tumor inside. You can see we try to remove if we can en bloc, but you know this is not a dogma. We can also remove in a multi-layer fashion the tumor. The goal is to have free margin. So later on, we drill at the level of the olfactory cleft, at the level of the periorbit, and we drill at the level of the anterior roof of the ethmoid. Okay, and as you can see here, we drilled and removed the septum, the mucoperiosteum of the right side, and the quadrangular cartilago and the vomer and the rostrum. So we expose the olfactory cleft over here, and we expose the crista galli. This is another important trick. If you want to flip the flap covering the ethmoid, you need to have a good angle in the upper part. If you have the crystal that comes down, it will make, you know, it will be like a hook here, and the hair can be inside, and there is not a smooth surface. So I always drill at least the lower part of the crystal galley when I perform the flip flap, or I remove the crystal galley. So here we are drilling the crystal galley here anteriorly, you see, crystal over here, and we drill till we'll have a smooth surface here in the upper part. So exposing the olfactory cleft, the ethmoidal roof, and then of course we have to remove the bone covering the ethmoid. Over here there was the tumor, so we send this bone to know if it's involved or not. But if the tumor touches the ethmoidal roof, we will open the dura, because through the olfactory phyla, the tumor can go towards the brain. So here we are removing the dura, you know, the arachnoid, these white stripes here is arachnoid with the bulb over here. So we remove the dura and the bulb. And then fascia, as I told you before, intracanally, intradurally. This makes the dura migrating on the surface of the fascia, originating a separation between the nose and the brain. And then now you see, we start to harvest the flip flap. So anterior incision, again, here is the posterior wall of the frontal sinus. Here is the incision, is more anterior and then turns posteriorly. But don't go straight, if not it will be a failure. So again, anterior incision. Over here you can use a beaver, you can use a monopolar, we don't use it, but if you are confident, let's use it. You can use a dioded laser, let's use what you want. And here posteriorly, we cut the posterior incision, it's at the level of the anterior wall of the sphenoid. And as you can see, we turn the flap up. Here we use this was an idea to use some fat from the leg, from the plastic surgeon, to improve the regeneration of the dura, but it's not the goal of my communication. Anyway, here the flap is turned at the level, laterally at the level of the anterior skull base and the periorbit. Let's see here the flap turns anterior skull base and covers also the periorbit. 42 months later, this is the postoperative control. Let's see here, sphenoid, and let's see. It's marvelous, the healing. Before this kind of flap, we use mainly fascia. There were a lot of crust for many months after surgery. In this case, after a month, it seems that he did not have skull base reconstruction, because it's a perfect healing. It's vascularized, and as you can see, it's preserved the contralateral olfactory cleft. So if at the end it will not be a T2, a T3 or T4 tumor, but is a T2 tumor, and you don't have, for example, to perform radiotherapy, you can preserve at least for an half the olfaction. And this is very important for the patient. And another example, there was a snack. The snack is not surgical. At the beginning, he had chemoradiotherapy, and after this treatment, you know, there is some tissue remaining at the level of the ethmoid. So our indication was to move on towards surgery and to check if there was tumor or not in this area. The resection I showed you before. So I move directly towards the reconstruction to gain time. And so we are at the same final time of the last surgery. Here, the duraplasty, fascia, and some fat, and then anterior incision and inferior incision. Here, I did not remove too much the periorbit, so I did not extend my flap on the nasal floor. Here, this is the right side. You see, inferior turbinate of the right side, middle turbinate, superior turbinate, and here there will be the natural ostium of the sphenoid on the right side. So anterior incision and inferior incision. The length, you can modulate the length. Then we coagulate the septal branches of the sphenopalatine artery over here. Remember, if you not, you will have postoperative bleeding when you perform the posterior incision at the level of the anterior wall of the sphenoid. And you can see, you can flip the flap up. And it covers perfectly till the posterior wall of the frontal and till the planum here posteriorly. Of course, you cannot use this flap for defect of the posterior wall of the frontal sinus or for defects of the planus phennoetmoitalis. It's between the posterior wall of the frontal sinus and till the level of the anterior wall of the sphenoid. This is the correct indication, and this is the postoperative control after 1 month. But let's see what happened 50 months later. The sphenoid remains open. The right ethmoid, it's normal here. And in the upper part, you can see the contralateral olfactory cleft and olfactory fibers preserved, and the flap covering the anterior skull base till the orbit here. And the last case, and then I will give the word to Puya. It's another use. It's for meningoencephalocele. Let's say this patient, he performed before surgery, previous surgery, for a meningoencephalocele of the ethmoid, and she, because she was a female, she had again CSF, meningitis, and rhinolicorrhea. So she was referred to me in order to solve the problem. So first option, how would you deal here? It's a recurrence. It was obese, the patient, so probably with hypertension, and of course, I know that there will be scarring tissue at this level where there was this meningoencephalocele. So at the first time, I thought to use an adult flap. And this is me here working, so I performed both surgeries with adult and then with the flip flap at the last time. So let's see, posterior frontal sinus, posterior wall. This is the defect, quite a big defect of the anterior skull base. So as usual, when we, with Castelnuovo, we try to reduce the mass, to smooth all the edges and to identify the origin of the meningoencephalocele. Then we tried here to make a gasket seal. You see, we put some fascia, and then with cartilago or bone, we tried one, but it did not work so well. So again, we took away the cartilago, we put the fascia towards the brain and tried to reinforce with this gasket seal technique, but it was not so good. And reduce again the brain herniating, then covering, and again cartilago. And we want to hear the click that goes inside and take the fascia against. You see here, it was quite good, but here posteriorly, when we know that it was a small defect, we put some fascia. It was not perfect. It was not perfect, of course. Then, okay, it was not perfect, but we thought we put a very huge adult as a third layer, and it should be sufficient to solve the problem. And this is what we did. But after 6 months, again, the patient, after 10 months, the patient referred to us for meningitis. And looking well, there was some CSF, some laryngorrhea. And so what to use? We use multi-layer, we use the first surgery in another institute, we use the gasket seal, more at that flap. So the idea was try to use the flip flap. So here we started again. You see with the fluorescein, you can see the defect. We are sure that the patient is leaking here in the posterior part of the nasal fossa. And so we removed the Haddad, the third layer, the Haddad flap, exposing again the defect. You see, we are pulling down the Haddad that we previously put at the level of the defect here posteriorly. It's bleeding, so it was vital. There was not a necrosis of the flap because there were bleeding, it was bleeding the flap. Here, the meningoencephalocele again. So, failure. You see, with the fluorescein, you can very well understand where the defect is localized. So, again, we coagulate the herniating brain over here, but it's not enough. We want to arrive at the level where the brain comes out. So we need to arrive till the bone. So coagulating again, removing all the scars. Here, removing the posterior part of the remaining Haddad flap over here, and we remove it with the bridle. And then looking for our landmarks, the sphenoid was closing over here with the Haddad. And then smoothing again, removing all the septal. And here is the defect. Here, at the level of the medial part of the ethmoid of the olfactory cleft of the left side. So now we arrived at the origin of the meningocele, and so the idea was to remove here the bony part and the cartilaginous part of the septum, and to use the flip flap. So I want to go a little bit faster. Here you see we remove the bone here posteriorly, mucoperiosteum of the right side, and as you can see, we flip here the flap posteriorly. You can modulate also the length. Here it was quite posterior, so you don't need to have too much, to come too much anterior with your free flap. But as you can see, it covers perfectly the defect. And this is the post-operative control. I'm sorry. Opera. Coana, remaining part of the septum, axillary side of the left, and here the healing after 1 year. And I hope this will be the last surgery. And Puya, you can go on with the results.
Thank you, Paulina, for the presentation. So the step-by-step was based on this type of cancer at the beginning, then switched also for repairing for cases like CSF. So what we are going to do right now is to have some look for the data that we collected. So in order to do it, I have to share my screen and we will talk about a little bit more. So here it is. The presentation today is going to talk about what are the preliminary and the long-term outcomes of the whole flap. So as Paulina said, the reconstruction of the anterior skull base defects remains the most challenging issue in the postoperative CSF leak, ranging from 3.3 to 4.3, according to the Rhinology position paper. So there are various surgical techniques and different materials used for defects and repair. The introduction of the nasoseptal flap, as Paolo said, dramatically decreased the postoperative leaks, but there's some problems regarding the defects that are reaching the anterior portion of the cribriform plate. So that's, in order to address that, we on the last paper that we published, we have some alternative pedicle flaps for the reconstruction, and here we are with the septal flip flap, which is based on the septal branches of the anterior and posterior ethmoidal artery. So the preliminary results were published in 2016. We published those results based on a period of surgery between June 2014 and February 2015. And then we analyzed patients. There were some patients that were initially 4. We had a follow-up period of 36 months with those patients. And then the exclusion criteria were essential at that point, because we have to look for the oncological viewpoint exclusion criteria, which are the extension of both ethmoid complexes. We cannot use it if we have an involvement of the nasal septum or the planum sphenoethmoidalis, or cases with multifocal histology like intestinal type adenocarcinoma, which is not quite like right now. We changed it. So that was the first part. The technical viewpoint, that the exclusion criteria is that if we had already a previous nasal septum surgery, like a septoplasty, where we have already damaged some vascularity of the flap or the mucosa, or the cauterization of the ethmoidal arteries for epistaxis or other regions. So here's the results for the first part. No evidence of disease after 36 months follow-up, and no of the patient developed necrosis of the flap after adjuvant radiotherapy, which was pretty amazing. So then the long-term outcomes completely changed the field. So we started from 4 patients, and right now the period of time is different. July 2014 to July 2018, 24 patients, which were 16 male and 8 female. The mean age was between ranging from 16 to 79 years old. And also we had some patients that unfortunately were unable to have the therapy. We will see after that. The defect size was in this time reported because we estimated the size of defect following unilateral craniectomy, ranging from 2 centimeter to 6 centimeter, and 13 patients where we found having defects between 2 and 4 centimeter, and other 11 patients were between 4 and 6. So some of them bigger, some of them not, so equally. Those are results. Main patients were actually intestinal type adenocarcinoma, so 10 patients with that. We had the successful results in 23 patients upon 24, and we will analyze better that. The follow-up patient, we have 22 not evidence of disease, 1 patient still active with disease but is still alive, and unfortunately one of them died. It was a patient with a squamous cell carcinoma T4A N0M0 who was dead after 14 months after surgery, followed by adjuvant chemotherapy after developing, however, lung and liver metastases, which is different. So, but even after that, no one of the patients is still alive, developed necrosis of the flap after radiotherapy. The complication where exactly one of the patients developed a seroma in the fascial lateral donor site. Another one has a frontal lobe abscess, which was treated with antibiotic. Another one had to do another surgery because there was some leakage in the anterior portion of the defect. So we put it once again in the surgery room and covered the defect. So in conclusion, based upon 4 years, those are from the preliminary to the long-term results, it seems that it works pretty good. So it seems that it's a safe and effective technique. And have a high success rate similar to those obtained using the other pedicle flaps. But as Paolo said, you cannot reach to anterior portion of the cribriform plate. So how about that? we cannot use the nasal septal flap because we cannot recover that. Plus, the advantage of this flap is that if you harvest it in a proper way, you can use it also from the contralateral floor of the the pavement of the contralateral nasal fossa to cover also defect from the orbit, so which is pretty good. But the important thing is that this flap ensures greater speed in healing process. Paolo shows you the beautiful aspect after a short period of time, a longer period of time, by leaving open the frontal sinuses and the sphenoid, which is amazing. So is giving a reduction of nasal crusting. The amazing thing is that can be used in patients who have previously or are expected to undergo chemo radiation, and the reduction of patient discomfort, which is pretty good. So I was fascinated. I was delighted from Paolo for involving me in this paper and in this work, which was during my period of staying in there. This was a picture in 2014 when I was part of the team. It was a pretty amazing. That period of time let me understand exactly how many possibility do we have when you're part of an amazing team. At that time, Paolo and the other groups, Mario, Akis, Federico, and everyone were doing lots of study, and I was blessed for being with them. So I think that if you can just end the talk, Paolo, and reply to some questions, it will be amazing.
For sure.
So let me go here and check questions and answer from the patient. So here's the first question from Russia. Our colleagues is asking, would you suggest to use this flap if you have a contralateral involvement of the cancer of the mucosa of the nasal septum?
No, this is a real contraindication. If the septum is involved or the tumor goes contralateral, it's absolutely not to be used, this kind of flap. It has to be monolateral without septal involvement.
Okay. Another question that is coming this time from France is that how can we support this? Is the vital flap?
Oh, how can we say that it's vital?
Yeah.
Oh, because we use also, this is, the anterior ethmoidal artery, the septal branches are used also to close the anterior septal perforation. So it's vital. If we inject the ophthalmic artery, there will be some blood that goes towards the septum. So of course, it will be vascularized by the ethmoidal arteries. We are sure about this. It's not a random flap. It's a pedicle flap.
And that's the beauty of this. It's I think that is strongly vascularized because both of the arteries. So you have two
arteries, not one.
That's the main thing. Another question from India: are you packing the nose after positioning the flap?
Yeah, we pack, but I suppose that you can think also not to pack if you don't have any bleeding. You can also not to pack. The pack is only to not to reduce the bleeding of the cavity, but it's not to give support to the flap. It's a tensiotive effect. You could also not to pack. Sometimes we don't do this frequently because the patient, we don't put the patient in intensive care unit. Usually the patient after the surgery stay 2 hours under control by the anesthesiologist, and that comes up in our clinic. And so it finished late in the afternoon, and there could be some bleeding. Then the nurses call the colleague during the night. So we prefer not to have any bleeding during the night for the next two nights. But if you feel safe and you feel that it did not bleed too much, you can also not to pack.
I think that no one wants to go back in the OR doing the other question.
I
This is a
suggest you
friend.
to quick.
There's a question for one of our colleagues. Is do you use it for adenocarcinoma with a multifocal background theory?
So this was a dogma till I think 10 years ago, no, but perhaps less, till 5 years ago. You know, there was the Belgian school from Belgium that was saying, we do monolateral, we don't have recurrence on the contralateral side. We are Italian, and we follow the idea of the National Institute of Tumor that had a great experience, and they told us many times during Congress, pay attention because you can find foci on the contralateral side of the ethmoid. So when you have an adenocarcinoma, you have to remove the ethmoid bilaterally. So there are two opposite ideas about to treat one or both ethmoid in case of one side involvement. So we are doing now a study, a blind. So and we now are comparing our further experience when we remove both ethmoid, and now we, if it's possible, the tumor is monolateral, we do a monolateral resection. Till now, we did not have any recurrence in the contralateral side. And so we will try to have homogeneous cohorts to be compared, but this is, I can give you the correct answer some when I will be older, when I will be 15, 10, in 10 years, I think, to be sure if it's safe or not to remove only one side.
Yeah, I think that more studies should be carried on this field, but we need time. However, everything's changed from, for example, the neck dissection that goes always saying you have to do an unblocked resection, but then we find out you can do piecemeal resection and then just, take it off. So it takes time. It's fascinating how much impact changed the endoscopic sinus surgery in 15 20 years. So we change from a mid facial degloving on open approaches, and then we can do most of the activities with the endoscope. So it took time.
Do you imagine what Castelnuovo and Piero Nicolai had to hear from the ears when they starting say, okay, we remove piecemeal the tumor? Yeah, it was like to go against a dogma. So there are dogmas that had to be demonstrated. Until now, we don't have a scientific answer, but we will see.
Well, we'll see. Yeah, same colleague asking question: do you need to remove the crista galli always?
If you deal frequently with this kind of tumor, it's not so complicated to remove the crista. But if you are starting this surgery, the tumors, you have before starting tumors, you need to do phlogistic, etc., etc., etc. If you are not so confident with the crista, let's drill the base of the crista. You can not have a CSF there. So if you don't want to remove, let's drill the base. It's better to be removed, the crista, yeah. But it's not also, if you don't do it, it will not work. You can turn it better if you remove all the crista, but you can drill the base also.
Yeah, like when you're doing the anterior reconstruction, the aim of removing the crista is for the positioning of the fascia. So will let you have a better position. Otherwise, you cannot do it because there's in front of you. So I think that everyone is enjoyed a lot. There's so many people right now. There's around the world watching us. So I think it's about the time to say hi to everyone and have a great weekend. Thank you, Paolo, once again for being with us. It's the fourth time that Paolo was attending and giving an explanation for
Are
those
you saying it's the last time?
It's not going to be the last time. This is very important for me to say this. Paolo was one of the few that believed in the association back in 2014 and 15 when I decided to develop. He was I had the blessing from Castelnuovo when I was in there and asked him, do you believe in this kind of thing? And Paolo was always supporting. Paolo, Mario, the other guys, everyone supported that. And after 5 years, everything is getting bigger. We're getting results. Article published. We are recognized worldwide. So Paolo is one of the main faculty member of the association, and we're really glad to have him because of his amazing technicals and research skills. So Paolo will be more involved in the future. So you will see more and more about to come in the future. So thank you, Paolo. I hope
Thank
that
you.
you enjoying and you also spending your time, because today is Saturday 2:30. Many people can go abroad and having enjoying the life, but you keep continuing your educational purposes, which is very brilliant. Thank you, Paolo.
Thank
And
you.
I hope really to see you back soon because it's about the time. I love you. Grandissimo. Cheers to everyone.
Grazie Puya, un abbraccio.
Oh, I'll see everyone on Monday with Anderson Eloy for the open and endoscopic approaches for refractory chronic sinusitis, and on Wednesday and Thursday and Friday and next week again. Ciao, ciao.
Ciao.